housekeeping notes. First and foremost, this webinar is being recorded. So thank you all very much for attending the first webinar of the fall semester for the AAA. Today we have the distinct honor of hearing from Lenore Manderson. She is an internationally known anthropologist focusing on social history and public health. And she's played a lead role in training and researching in inequality, social exclusion, marginality, the social determinants of infection and chronic disease, gender and sexuality, immigration, ethnicity, and inequality in Australia, Southeast and East Asia, South Africa, and Ghana, and most recently in the Solomon Islands. She also, with Elizabeth Cartwright and Anita Harden, will be producing a forthcoming anthology, the Routledge Handbook of Medical Anthropology, coming out in 2016. Should be very informative, and you'll get a little taste of today. As a note, you will see a Q&A tab and a chat tab. If you have technical questions that need to be answered immediately, it's probably easier to use the chat tab, and I'll respond to those directly. And if you have more general content-based questions, feel free to send them to the Q&A tab, and I will direct those when we get to the Q&A section of the conference. There will be a 40-minute discussion from Lenore, followed by opening up the floor to your questions. And without further ado, I turn it over to you. Thank you very much for being here today.
Thank you, and thank you, people. I made the fatal error of seeing who's online and therefore realised that some of my peers are online, so hello to you, and peers meaning people that I know and I've worked with. What I want to do is to start by getting my, what I'm going to do is to be talking around a number of themes that have emerged in some work that I've been doing, as Andrew's described. But in doing so, I think I'm more flagging areas that I see to be emerging issues for medical anthropologists to look at, or questions we haven't engaged with sufficiently at present. To some extent, it's a wish list of research, but it's also areas of research where I feel we can be effective in practice as well as in theory, and I'll explain that more as I go along. For those of you who don't know me, I edit the journal Medical Anthropology, and I've done so since 2010. And many of the ideas that inspired me to pick up the task of the handbook have been from the kinds of things that people have written about in the journal. The handbook itself is, as Andrew said, coming out next year. The second half of the material goes to the press in 7 days, and it should be published in April 2016. But in addition, much of the work that I've done over the years in Asia and in Africa to a lesser extent has informed what I want to talk about, and that includes work that I've done in a consultant capacity as well as, and committee capacity, as well as an academic. So what we're going to do today is talk about changing childhoods, chronicities of illness, climate change, war and violence. And in that context, I want to pull out issues around comorbidities and the co-occurrence of illness, about complications, about intersections and the intersections of health systems and social determinants of health and of diseases themselves. And so therefore, to some extent, pick up on Meryl Singer's idea of syndemics. I've chosen this picture intentionally, partly if I can actually get this to work, we can actually circle it. Child, woman, man, moving through floodwater. And what this image really highlights for me are a number of the social determinants. A well for water there, rubble and dirt, and therefore one might expect polluted water through which people are wading. really a picture of poverty and somewhat overweight adults, maybe more than somewhat overweight, depending on where they're from and their own standards as well, and a fairly slender child. And that of itself really, for me, emphasises questions around the epigenetics of diabetes, the fact that this woman may well be at risk of diabetes, cardiovascular disease, and the sequelae of those and of their interactions. The first thing that I want to talk about is children. And children have surprisingly been less an object of research of academics than their mothers. We've spent a lot of time on looking at issues of pregnancy and birth, certainly women of my generation influenced by feminist anthropology and feminist activism. Far less time with infants, and certainly once they cease to be infants, once they're toddlers. Children tend to be a presence around anthropologists, particularly anthropologists working in domestic space. The subject or the object of research, if the question is around circumcision or marriage, but otherwise relatively invisible. And that has partly, I think, been our sense of children as unreliable informants, as well as people unable to theorise and unable to provide informed consent. But we need to be rethinking that, I think, because otherwise we're leaving out a substantial part of the human actors in the world today. Our interest has also been, let me just turn this off, our interest has also been in terms of technology, and in that respect, things like the humidity cribs and so on for children are part of the move amongst anthropologists to turn to technological innovations. I've included this picture not because it's high technology, but simply because it draws attention to one of the poorly researched questions, which is the abandonment of children. But linked to that, around formal and informal adoptions, around family making, and around what happens to children who are on their own, both children who are responsible for families, often the only income earners, children who are unaccompanied, who flee and become what are called in literature, the policy literature, unaccompanied minors. This is a much more typical picture, I think, of children, which is children as the objects of public health. And aligned with that is a continued enthusiasm by public health professionals of the possibility of eradicating various diseases. Now, that of itself is, of course, problematic because of the increased concern amongst small groups of advocates against vaccination, against immunisation, and so the re-emergence worldwide of diseases that we once assumed were well controlled. These are diseases that often have limited long-term effects in resource-rich countries, industrialised countries. I'm thinking, for example, of measles and chickenpox or mumps or rubella. But these are also diseases that can have profound disabling effects on children in poor countries. Children in detention have emerged both globally and increasingly for anthropologists as people with whom we need to be concerned. And I was interested that in Anthropology Today, which is the one of the journals produced by the Royal Anthropological Institute in the United Kingdom, there's an article on unaccompanied minors in detention. But the point about children in detention is the extent to which they are deprived of a range of things, of education, of general social interactions, of the possibility of engaging with others without fear. They're in constrained circumstances, they're at risk of infection, and they witness terrible acts from their parents of violence and of despair. The children in Australia, and I'll come back to this later if I have time, children who are detained by the Australian government routinely when they leave camps, report watching adults sew up their eyes and sew up their mouths. And we know very little about their well-being once they are released into the community. Children as workers. Worldwide, children work. They always worked in poor, small-scale societies, and we never regarded that as work. The idea of children as workers becomes a problem when they receive wages. And almost everywhere, children are underpaid for the work they do, and almost always because of their low levels of skill, and because they are usually illegal workers, they are underpaid. So in dangerous work and underpaid. This is a picture of children collecting recyclable plastic containers in order to make money. These are children who are from Syria, living in camps in Turkey, if you can see the very small subtitles of this UNICEF photo. But elsewhere, children work also collecting garbage, carrying water, making gravel, selling flowers, selling sex. And as I learnt when I was working with a colleague of mine, Susan Bissell, who's now with UNICEF in New York, children who work in the garment factory or in any other industry that is in part regulated internationally are very vulnerable if a decision is made to disemploy them and they end up on the streets, when those children, such as the ones in Dhaka that Susan was looking at, were the only income earners, and therefore their work was the one thing that kept their families together. I'm not arguing, of course, for child labour, but I am arguing for our need to think through policies, and the role of anthropologists is in part to assist in that process. Worldwide, children experience the kinds of a range of disabilities, both congenital as a result of a whole range of genetic factors, but also because of the conditions in which they live. They become disabled not only from disease or from birth defects relating to maternal disease, but also because of the physical environments in which they live. And these are often children who have become disabled through very external circumstances. To explain that, I was thinking, in fact, not about physical disability, but about intellectual disability. A colleague of mine, Vu Song Hao, who has a case study in the handbook, was doing her PhD on autism. And in Vietnam, something like 25% of all children admitted to paediatrics hospitals are defined as autistic. That seemed to me an exceptionally high number, until I reflected on the possibility that that might also be linked with a range of other defects that are related in turn to the war. And if you Google disability in Vietnam on the web, which you might like to later, you will see hundreds of photographs of children who are physically disabled, often born without limbs or with facial deformities and tumours, presumably many related to the Vietnam War and to the continuing toxicity of soils. Let me quickly move on to chronicity. The chronicity I'm referring to, and I referred to in a book with Carolyn Smith-Morris some years ago, is around the ongoing nature, not only of health problems, but the ongoing nature of the conditions in which people live. And it's the intersection of being very poor, being in an environment without infrastructure, and chronic illnesses that combined lead to deteriorations of health problems and produce ever-increasing numbers of them, while also driving down household wealth and capacity to be resilient in the face of disease. The point of this picture is, in fact, to highlight the conditions under which many people in the world have access to water. And you'll see that already I'm moving across the theme, so that in children I've talked about war, in chronicity I'm now talking about climate. But the point of this photograph also is that water is a vector or an environment of infection, of parasitic disease, of bacterial and viral diseases. And people who lack access to potable water, drinkable water, and lack access to clean water for themselves and their bodies, for their clothes, their implements in kitchens and so on, are always at risk of high rates of infection. But these kinds of chronic diseases are ongoing in many ways, and they're also often readily resolved through medication. The problem with many of these chronic diseases, when they are parasitic infections or other infections that remain in the environment, is that unless everybody was treated at the one time, then people will become reinfected. Hence the development of mass drug administration and eradication campaigns, as in this case, which is about onchocerciasis, which is also known as river blindness, which is the endpoint of that disease, and which can be treated once a person is infected, although usually over many years. And that's a real problem. So it's not even the banner behind these people is misleading. It's not if I had taken onco tablets, I would not be blind. It is if I had taken an onco tablet once a year for 13 years, then I may have controlled the macrofilaria and then I may not be blind. And so I think that it's not as simple as it might first appear. But relating to that is, sorry, if I let me just stick back to that, is the difficulty of organising this and the problem of health systems in order to procure the drugs and to distribute them all at the same time to ensure that people take their drugs and so on. Melissa Parker and Tim Allen from the London School of Hygiene and the London School of Economics have written a few trenchant articles about the mass drug administration programs of Tanzania for schistosomiasis and filariasis, and in the process have become demonised by people who see any criticism of mass drug administration as running the possibility of destroying all of their work. That's not true, and anthropologists must be critics where we see cause to be critical. One of the problems with chronic complaints of any kind is that people are necessarily always having to engage with the health system, and often in ways that are not particularly comfortable and that compromise their privacy, their confidentiality. I was struck by this picture, really just because there is one woman being questioned by 4 staff. One of the problems with health services in poor countries is not enough staff, but how staff are deployed seems to me also an issue. The other point is that if this woman is presenting because of the care of an infant, which is what I think she's got in her arms, there's not much of a problem. If she's presenting for any other health problem, then there is a real issue there. She is not going to, in front of 4 women and possibly dozens of other people behind her, talk about intimate partner violence, sexual health problems, reproductive tract infections, or HIV. HIV is now a chronic disease. It was 30 years ago a disease that was a certain death in a very quick amount of time. So it's transformed as a result of the medication that is available. But it would be mythical to propose that it was normalised and that HIV was, quote, just like diabetes. It's not just like diabetes, because HIV, despite ART, is deeply stigmatised, and people have great difficulty in presenting for care and in returning for care or for monitoring. Some of the work that's being undertaken with me at present here at the University of Witwatersrand highlights the extent to which men and youth without their own families especially are reluctant to present for care. Women are able to present for care to some extent because they have children, and so their access to care is normal, and people expect to see women with babes in arms at health centres. They don't expect men looking more or less healthy to be turning up unless they have HIV. And in much of the world today, HIV continues to be the cause for people losing housing, losing employment, and being excluded from their own communities. So despite the fact that we've spent some 40 years, or 30 years I mean, looking at HIV and worrying about stigma, we certainly still have much work to be done. I want to talk a little bit about the environment beyond the issue that I'd already drawn attention to before, which was around the quality of water that people had access to. From 2010 to 2013, I was a member of the Steering Committee on Population and Environmental Sustainability with the Australian Academy of Science. And that was at a time where we were hopeful that we would be able to supplement the work of the Climate Commission in Australia. The Climate Commission, as it was, no longer exists, and Australia is one of the few governments in the world that pretends that climate change is still a scientific myth. Those of us who have been involved in advocacy in Australia and in undertaking research remain deeply concerned about it. And mindful of the changes that are happening, including global policy changes. And one of the things that anthropologists, including medical anthropologists, have been concerned with is the impact of climate change, including on human health and including on animal health and the relationships between the two. In that context, I have been for many years working with the World Health Organization's Special Program for Tropical Disease Research and Training, and I'm currently on a Vector Environment and Society committee looking at issues around climate change, including the possible impact of loss of biodiversity on human health. But in general, climate change means changes in the distribution of disease. It means changes in the habitat of vectors and impact on all people. It also, of course, impacts on health by causing impoverishment, and the kind of picture here in this slide emphasises that. Floods. Medical and environmental anthropologists are beginning to work on questions of ecology and disaster. Hurricane Katrina made clear, in the United States at least, that structural vulnerability, state neglect, corporate violence, all created a disaster far greater than the storm alone. Yet this violence is replicated each year, not less because of the skewing of concern between, say, a storm on the eastern seaboard in the United States and one of even greater intensity in Pakistan or elsewhere in the world. Health impacts most where people are stripped of all resources, yet there is little research still in this area to drive this home. Environmental hazards from human activity have led to us to talk about the Anthropocene. The world we live in is human-made or human-distorted. A range of activities undermine human health directly and indirectly, and you can think variously about fracking, fishing out waters, diverting river water, industrial pollution of groundwater or waterways, and air, heavy metal pollution, and the like. And always there is a competition, it seems, between economics and human health. Increasingly, we are seeing refugees from environmental disasters and from inhospitable climates as a result of climate change. The desertification of Africa is but one example. What is implied by this is that people choose to move on the assumption that they will be able to find a better, more hospitable, more productive place. Although in most cases, people who are displaced live in vulnerable conditions, often exactly like the ones they left behind. In a few cases, anthropologists have been able to conduct research in such environments. Matthew Wilhelm Solomon spent time in a camp in Uganda. and was able to highlight the ways in which the social divisions of the outside persist and compromise health and well-being within the camps. People are vulnerable to the internal divisions as well as to the policies of international agencies supervising those camps, agencies that ensure basic health and mediate their reintegration into mobility. And I'm thinking, for example, of the way in which people with HIV in the camp that Matthew looked at were not so much discriminated against, but distinguished. Their food came on a different day. Their water came in different containers. They had medicines distributed at a different time. And it was therefore impossible for anybody in the camp not to know who was HIV positive and who was not. There are now 13 million refugees worldwide, and there are 38 million people displaced each year. I mean, worldwide, 30,000 per day flee from civil war, discrimination and violence, weather, or all of those factors together. Syria is only the most recent and the worsted case at present of those trends, but one might also reflect that the wars of places like Afghanistan or the southern Philippines or Iraq are often now multiple generation wars with few signs of real resolution. And we must also consider state violence, including, sorry, that's paper flicking over, against Palestinians, the Burma government against minorities in that country, and the violence from anti-government groups, Boko Haram, for example, in Nigeria, so that there are wars everywhere which are waged on the air, remotely, through drones, and on the internet. And that's a change from the wars, for example, 50 or so years ago, indeed even since the Vietnam War. Conditions in camps compromise human health in multiple ways. I've spoken of Matthew Wilhelm Solomon's example, but there are many more one can think of. We know that even the most organised camps, this is a photo of a UNHCR camp, and one assumes it is reasonably well organised. Those kind of camps, food and water can be supplied, basic sanitation, basic immunisation, perhaps for children. It is possible that there is obstetric care, but it is unlikely that there is good enough emergency obstetrics to save some women, for example with placenta previa or placenta accretia. Sexual violence has been documented as endemic in all camps. Child abuse is endemic. Rape is common. And so is ordinary interpersonal violence, if there's such a thing as ordinary interpersonal violence. Medication for other problems, including for chronic health problems, is often rare, and so that raises further problems. And more so, governments are tired of supporting camps like this and supporting the vast numbers I've mentioned too. And I think that there is a huge problem there. Boat people have become an enduring symbol, particularly this year, but in the last 3, 4, 5 years. Boat people used to be the people who we all reached out to support, the people leaving Vietnam when we, Australia and the United States at least, were deeply committed to a war in Vietnam. Now boat people are seen as nuisances to be kept out from Australia, from Italy, from the United Kingdom, from elsewhere in Europe. And it's the desperation that's so deeply shocking when this group of people are routinely characterised as illegal immigrants jumping queues rather than desperate people resorting to desperate strategies with the possible loss of life as a result. One of the problems for this group is also their treatment on arrival, and those who succeed in landing or in being in a third country waters are often apprehended and placed in detention. In Australia, the findings from a Royal Commission into camps for people who have been detained are profoundly shocking, and I've referred to that before, including for children who witness adults self-harming, attempting suicide, and indeed succeeding. People who are able to flee and to get to other places have few skills that they bring other than their own physical capital. Rarely can somebody who is, quote, illegal, unquote, able to get a job that is commensurate with their skills, if they have skills. They also, of course, may not have a language. And so people who migrate to often flee from frightening circumstances are routinely in a position where they must work in dangerous jobs. This particular photograph is of people mining for gold, and they're exposed to heavy metal. Elsewhere, labourers are underpaid, working in agriculture, in factories, or working as sex workers. Lack of papers means lack of access to healthcare, and for children, lack of access to education. Lack of protection for employment, lack of access to secure housing. And in all of those contexts, people are stripped of a right to health by virtue of the lack of other resources. People often receive no pay, not for a short period, but often for months. Suzanne Huschke, in a PhD she did when she was at Free University in Berlin, documented one man who had received virtually no pay at all for nearly 20 years and chose to stay more or less in hiding under the radar of the German government because he had felt he had no option. He had fled from South America. Recent books and articles that have come out in the United States provide a similar example of people who feel that to some extent they have abrogated their rights when they have chosen to flee insufferable circumstances. Another colleague of mine, a friend in Melbourne, Megan Wilson, writes, including in the handbook that we're just writing and editing, of people from Burma in Chiang Mai. One woman who had spent 7 years sleeping in and never leaving the factory grounds, relying on others to bring her food, without healthcare, without contact with other humans, other than at a workplace. Those who are able to travel across borders, legally or not, in this context, are perhaps the lucky ones. And yet, lest I end on a particularly negative note, and I'm very mindful that I'm sounding negative, I want to put up a couple of pictures which I think forces or encourages to think about the possibilities of change in human health and the ways in which technology might work as an advantage rather than a disadvantage. Much has been written, and including by us in the handbook, about markets. And that's partly around markets for medicines, and in that context, influenced by the work of Joe Dumit and Drugs for Life. But the markets of medicine are only one market, and increasingly there's both a growing market but a proven advantage of a range of other technologies, not only computers, but also the way in which smartphones and tablets are able to be used. The fantasy of e-health, of improving people's health by ensuring information can move readily, is long been surpassed by the possibilities of M-health and M-mobile health, not only in terms of transmitting information, such as X-rays and MRI results across cities and between countries, but also the use of apps and peripherals so that one very easily now can do an ultrasound with an iPhone. The stethoscope will soon be plug-intable to an iPhone or a tablet. Blood glucose monitoring and a range of other diagnostic and other technologies. And I think that there is great potential there to empower health workers in poor settings. So I want to close on this picture, which is one assumes a local health worker using an iPhone and checking a manual, rather than sitting in an office, buried under piles of paperwork, incompletely filling in forms, and unable to do the work she is expected to do. So I leave you with that as a way of thinking about it, and I hope that I have mapped out some areas that I think are important, and at the same time pulled out the intersections. And the one thing we have all been trained to do is to think around those intersections and how we might best bring them to light in a way to provide some solutions to poor health. Thank you.
All right, thank you very much. And so now we will open up the floor to the Q&A section. And something that I always like to ask our speakers is, about the applied side of anthropology, which you definitely went into, but specifically, how would somebody get into practicing medical anthropology? Given that there are not so many faculty jobs, what would it take to get into medical anthropology?
Yeah, thank you for that. I think you're right. I mean, firstly, many more people are training as medical anthropologists now than in the past, but there isn't a commensurate number of jobs, so that we do have to be thinking around where else can we as anthropologists work. And at the same time that there has been a staticness in the academy, there has been a growing appreciation of the kinds of skills we bring through other sectors. And I'm thinking, for example, of local government councils, of NGOs, of aid agencies, of course, because to some extent that's a continuation of a very old anthropological jobs, international agencies, foundations. So all of the international agencies, for instance, which is not that they're all busy advertising for medical anthropologists, but all of them include anthropologists. So World Health Organization, UNICEF, UNDP, United Nations, Human Refugees Commission, and so on, are all places where people work. Many consultancy firms have anthropologists with them, sometimes disguised as communications people or in some other capacity. But I think that we do bring skills that are widely recognised, and while the job may not be the one that we believe we were trained to be doing, there are ways of making it the kind of job we want to do. And I've been struck by the number of people, say in Africa, who work in NGOs, and in many countries in the world, much of the healthcare is delivered through NGOs, not through governments, because of lack of government capacity. But organisations like Save the Children and Oxfam and so on all have anthropologists. So incidentally does Intel and various health management organisations.
Oh yeah, Intel definitely.
I mean, sorry, just talking on that. What do you think, Andrew? I mean, it is also a case in that context that it's up to us to be, or to be putting in and to be taking a risk and to be seen to be providing skills. It is not the case that a local council is going to say, of a position vacant advertisement, degree in medical anthropology would be preferred. But I certainly know people who work in that area because they've been able to argue their own way in.
Well, so kind of, I guess, as a follow-up to that question, as a note, you can submit questions in the chat or Q&A tab. Both will get to the same place, so feel free to use either. But as a follow-up to that question, what, someone who was trained in anthropology but wants to make the transition over into an NGO or in a consulting, what kind of training beyond the standard anthropological training do you see people needing to make that jump?
I mean, I think it depends on the job, and it depends on the field in which a person wants to go. I suppose one thing that's happened over the last few decades has been a democratisation of higher education. And that's a good thing, but it also means that many of us look more or less the same as the next person. So then there is a question around specialisation and of bolstering up one's basic training, but that includes at a higher degree level with other kinds of training. So one might be looking at, for instance, doing an MBA. Many people who train at a doctoral level in the United States do MPHs, Masters of Public Health. That is not the case in much of the world, but the choice really is whether you do an MPH or a similar kind of training early in your career, or you catch up on the run. And arguably, the competition is such that now you really need to be thinking fairly creatively about how you market yourself and the value of doing, and say, an MPH concurrently with early PhD work. But MBAs and things shouldn't be sneered at insofar as they're not just about working for big corporations, but for someone who's particularly interested, it may provide particular managerial skills that also make you sellable. Health communications or anything else. And I think that, having said that, that experience early on, including in terms of internships, are also ways of giving people experience that allows them to both get a sense of the diversity of work and also to have an advantage at the point at which they're putting in for jobs.
All right. And so actually, it's from a question from Cesar, which is, can you say a bit more about the methods or the changes that ethnographic research is undergoing in medical anthropology to tackle some of the issues you mentioned?
Yeah, it's really interesting, isn't it? Firstly, and I was thinking about this earlier today in a different context, which is that the numbers of us now able to do, quote, traditional field work in a small-scale society, a village in a small town, and spend 15 months in the field and do nothing other than collect data are long gone. And almost everywhere people maintain connection to computers and to internet and everything else. At the same time, we're being asked to be much more explicit about our methods. And I don't know that I'm especially pleased about that. I mean, I find it at times irritating to have to say how many people I sampled and why I sampled, where I sampled. And I get much more irritated as an editor when I read very, very standard statements around we use grounded theory in order to analyse our data and, you know, comparative method of coding, etc., etc. But that's clearly around the environment in which we work, both in terms of making transparent what we're doing, but also because we're publishing across disciplines and in other disciplines, being explicit about methodology is normative, you know, the standard structure of an academic article. Some of the methods I think people have played with have been tested and maybe fallen out of favour a bit. So there was a time some years ago when anthropologists, me included, and public health professionals were obsessed with focus groups as a way of collecting data and contrasting data. I'm yet, in recent years, I've gone right off the idea that a focus group gets any more data than a few good interviews and is harder to organise, so I'm not so convinced. There is questions around the utility of photo voice because it's also been a particularly popular method, partly because it's fun and it engages participants. But there is a question about whether that is particularly productive, and certainly not for some of the work we do. Other kinds of things mean people are playing with both formal methods of analysis, and to some extent, of course, anthropology has the privilege of being able to use any method because it fits in with our own understanding. I mean, we invented we did multiple methods long before anyone invented it as a methodological approach. And I think that that's right. I mean, I think that using the most diverse methods we can is a good thing, but I also think there has to be a reason for it. And adding in more methods for the sake of having a bigger menu is not going to necessarily produce good results or interesting work.
Yeah, no, I think actually so. That question came partially from Elisa, so I think if that answers your question,
Yes,
Elisa, then good. Yeah. So Alina asks what you think about autism and if it is a big issue or if it is a trick with statistics.
No, I don't think it's a trick with statistics. I mean, I know a few children who have profound autism, and those, or in one case, a young adult, and that young adult is a textbook case. I'm just thinking of a particular Australian girl, and if you didn't know what autism looked like, you do after you've seen her. And the same, I did work on disability in various places in Southeast Asia as well as Australia. In the context of work on disability, I wasn't looking particularly at autism, but I learned a lot both about what real autism looks like and about attention deficit disorder. And the people that I interacted with attention deficit disorder were not toddlers doing toddlery things or overexcited school kids running around their backyard or children who'd have too much red cordial. These were people who had profound difficulties in focus, concentration, social interaction, cognition, speech and self-care. And that they are not invented. And I'm absolutely clear about that. I think that the question is, and that's what people have raised, is the extent of overdiagnosis. And overdiagnosis affects a range of mental health problems and it affects physical health problems. And there is a risk that we are constantly looking for diagnoses when there is a simpler explanation. That's a very different question from from cause. And I think one of the other things is that if someone is diagnosed, then there is a pathway to intervention, and that in many cases people are desperate to get a diagnosis because it provides guidelines, people in that context being parents. But we all also, struggling with a health problem of one kind or another, will often hunt, and that's true globally, and that was what medical anthropology did 30 years ago. Look at the way in which people interpreted signs and symptoms of the body and mind and moved around healers in order to have a diagnosis, in order to be cured.
Kind of as a follow-up, do you have any further reading specifically about the relationship between anthropology and autism?
No, there's very little work being done. We have one chapter. I mean, I'll have a look, but so can you, of course, on Web of Science or something. We have a case study on autism in Vietnam in the book in chapter 2, which is out at the end of April, so it's in time for next year's teaching. but there has been very little work done. And as there has been very little work done with a lot of intellectual cognitive development problems with children, I mean, children are not well researched children, nor well children. And in the book, we do have a chapter on changing childhoods, which includes one chapter on children with diabetes and resistance, and this is around children who have type 1 diabetes. Then we have one chapter on children with extremely severe degenerative conditions and how they manage themselves and their lives and their parents and school and everything else. And one chapter on autism, which is Vu Song Ha's chapter from Vietnam. One case study, and one case study from Ria Reef on hysteria in schools in Suriname and Swaziland. And each of those four case studies, just to explain, in the handbook, each chapter has a series of case studies. So there's like 6,000 words or so, 5,000 words from Anita, Elizabeth and me, and then the text is intercut with these various case studies which provide ethnographic illustrations of the issues we're talking about.
All right. So this is probably more of a domestic question, but how do you find the interaction between medical anthropologists and government policy is improving? Is there an agency involved in the anthropological community at this time? Should there be more?
I think it's been something we being American Anthropological Association have really struggled and fought to achieve for some time. I mean, it is routinely discussed, and the reason why the AAA met every second year for a long time in Washington was about ensuring that we were present at the seat of federal power. Now, that has not had impact, I think, depending on the issue, but certainly many of us, including non-American AAA people like me, have been involved in some policy discussions. I was involved years ago in discussions around HIV and needle exchange, amongst other things. And so the federal government definitely sees us as a resource, at least for some things. You know, there's a whole social and behavioural research section. But parts of NIH, National Institutes of Health, that are concerned with ageing, with chronic disease, and I mean really across all of those, have anthropologists, including anthropologists on staff. So Suzanne Hurton-Roberts is a member of NIH. So we have input there. There must be anthropologists sitting in government offices, in the federal government, in the US, as there are anywhere else in the world. And so minimally, the training has, I hope, has some impact in terms of how they think through problems and problem solved. The question is, I mean, I think more broadly, to what extent do we influence the public? And to what extent are our views reduced to a couple of good, well-known names and then lost? I mean, most people with reasonable education would recognise the name Margaret Mead, but they're unlikely to recognise the names of anybody more recently as being an anthropologist and engaging in anthropological and health-related work. Now, I mean, and just to push that, Margaret Mead not only did coming of age in Samoa and started everybody thinking about sex in a rather freer way than they had before, but she provided anthropological input to the Food Commission of the United States government through World War II. Her name is used for an award for public medical anthropology, which is a co-award of the SFA, a Society for Applied Anthropology, and the AAA, really in recognition of that work, We don't think of her as an applied medical anthropologist, but she was as applied as anybody in an area that is not particularly high profile, that is food and nutrition. And that's true for plenty of other anthropologists in the past. Remember too that in the less noble past, anthropologists were very involved with government, medical anthropologists and others, through colonial enterprise. Now, anthropology got a pretty bad name, especially in terms of its political interests and the capacity of anthropologists to help governments, including the US government, dig out revolutionaries and control populations. But within any colonial government, there were anthropologists working around food and health and so on. And so there is that long tradition. I've been interested in the development of what is seen to be public anthropology and the support, for example, that the University of California Press has given to encourage people to publish their doctorates in the domain of public anthropology, which is explicitly intended to bring to light an anthropological take on problems of the moment. And I think that that kind of thing is a way of encouraging people to see their skills as more than a skill that confines them to academia.
Yeah, fantastic. Thank you. That was a great answer and great explanation, of course. I think we're coming to the end. So if anyone has some last pressing questions, please don't hesitate and put them in the chat or Q&A. But with that in mind, I do want to do some house cleaning. We have another webinar coming in 2 weeks, which follows Lenore's, or maybe continues the conversation on health, disease, and conservation. Definitely check it out if this is a field that interests you. But looks like all the questions curiosity has been sated for now. So Lenore, I won't keep you any longer. I know it's late. Thank you so much for coming. This was an amazing webinar, and I know everyone was very excited about having you here. And so thank you very much. The recording is going to be, for all participants, should be up in the next 30 minutes, but I will be creating a more polished version that I'll be putting up sometime next week. So thank you all for joining us, and thank you very much, Lenore.
Thank you for hosting it, and bye-bye everybody, and thank you for joining me too.
All right.